Bismillahirrahmanirrahim. My distinguished guests, esteemed faculty, respected consultants, colleagues, and dear participants. Assalamu alaikum and a very good evening to you all. On behalf of the organizing committee, it's our great pleasure to extend our heartfelt welcome to NephroCon 2025 hosted here at Ramada Hotel, Murray, and also we are streaming live for our virtual attendees from around the world. I, Dr. Sania Zeeb, along with my co-host, Dr. Zunaira Sajjad, will host this session. It's a true privilege to bring together leading experts, researchers, and healthcare professionals from around the globe to share knowledge, innovations, and advancements in the field of kidney care. Under the theme, Advancing Nephrology, Bridging Science and Patient Care, we have curated an enriching program featuring cutting-edge research, interactive workshops, abstracts, and thought-provoking discussions. Our goal is to foster collaboration, inspiring breakthroughs, and improve outcomes for patients worldwide. A special note of gratitude to our speakers, sponsors, and dedicated team whose efforts have made this event possible. To our attendees, your passion and expertise are the driving force behind this gathering. We encourage you to engage and take full advantage of this exceptional learning opportunity, so wishing you a productive, inspiring, and memorable NephroCon 2025. To formally open the conference, it's my pleasure to invite our mentor, Professor Dr. Muhammad Sajid Rafiq Abbasi, Chairman of the Organizing Committee and Head of the Nephrology Department, Pakistan Institute of Medical Sciences, Islamabad. Please welcome Dr. Sajid Rafiq Abbasi.
Bismillahirrahmanirrahim. Thank you, Sania. And thank you very much. First of all, I would like to say to all my distinguished guests, thanks for coming here, that you traveled very long. You came here and gave respect to us and making this NephroCon a successful event. First of all, I would like to share that why I decided to go and why I decided to conduct this NephroCon. For such a long time, it was my dream. And whenever actually I look back, I always thought that all the societies used to conduct their events at some hill stations, and there were multiple events, sometimes the summer updates, and sometimes midsummer meetings. And I used to think that why not the nephrology had some kind of a meetings. And you know that our chapter, the PSN, was always the biannual meeting. And that's why I thought that we should have some kind of PSN, or at least some kind of a meeting at a hill station. And when I thought it, I discussed multiple times with my colleagues, or even I wanted to conduct the main PSN meeting at hill station. But whenever I discussed with anyone, everyone thought that probably it's not possible due to the multiple strains, because the main PSN committee did not agree on this proposal. And most of my fellows, they thought that it's very difficult to organize. And then I decided to conduct it only on my behalf and with my few friends, and just on the basis of PSN. And only few person, and one of them is Professor Samij Khan. He was with me, and Dr. Khavar, he was with me, and my organizing committee from PIMS, they were with me. And some of the other consultants, they agreed on this proposal. And finally, today, this dream came to the reality. And thank you very much to all of you who are sitting here. You are part of this reality. Thank you very much. And I always feel that this is not actually a PSN, or these are not the nephrology. We are like a family. Actually, it's all family, and whenever you're doing some, it's not basically just a fun function, or it's not just to the hill station, but whenever we do the meetings or whenever we conduct such conference, that's actually exchange of knowledge as well. And whenever we have a meetup, at the same time we meet with our family, with our friends, with our colleagues, and with these interactions, our bond gets stronger. And that is the main basically purpose of these conferences as well. So my purpose is that as a community, as a PSN, we should have more frequent meetings so that we can exchange our knowledge, we can update ourselves, and our community should get stronger. And that is the purpose or idea behind this conference. And as long as when I took charge of this PSN as a general secretary, my basic purpose or basic motto is that this PSN should be more active, more proactive rather, to conduct more conferences, more exchange of knowledge, because sometimes I see that maybe I am working in a tertiary care hospital, having more chances to get access to the knowledge, but few of my colleagues are not working in the tertiary care, maybe on a different areas, not having so much access. So they should come to the conferences, having more interactions and more access to the knowledge. So that is the purpose. So welcome to this family, have a fun, and hopefully, and more fun. And maybe even during this, whenever I was conducting this conference, maybe at some time, if you had some kind of a inconvenience, I'm really, I would like to say apologize for that. And a few of the other things I would like to say, thanks to all those ones who contributed to this conference success, Professor Samijeh Khan, Dr. Khabar, and all organizing members of my PIMS, and all my president, Dr. Zaid Nabi, I think he must be here. So sir is here finally. So he's here. He's always whenever I try to do something, he's with me. And my friends, my Dr. Adil Ibad, and most of my friends here are always with me. And most importantly, I always mention the pharma companies. So they are not companies actually, but they are supporting us in academic programs. So whenever we try to do something, they stand with us, they support us, and they try to give us that financial support. So I think we should, I'm also thankful to them. And finally, let's hope that probably you will learn a lot from this academic activity and will have fun as well. Thank you very much.
My distinguished medical consultants, esteemed colleagues, and honorable guests, Assalamu alaikum, and a very good evening to all of you. My name is Dr. Zunaira Sajjad, and I will be hosting your sessions for the next 3 days along with Dr. Zania. Today we gather here to celebrate a momentous occasion with gratitude and respect. We come together to honor this special moment where we acknowledge the power of medical innovation, human resilience, and the unwavering support of our loved ones, which make us successful in the field of nephrology. As many of you know, CKM syndrome represents the convergence of 3 major disease areas: CKD, cardiovascular disease, and metabolic disorders, which is prevalent in population with obesity, hypertension, and diabetes. Ladies and gentlemen, in order to address this issue, we have among us a man whose name needs no introduction, whose expertise are beyond imagination, and his patient care is the embodiment of his successful career. A man loaded with degrees and is a leading expert in medicine with over years of experience. Dr. Sajid Rafiq Abbasi is a renowned nephrologist and expert in the intersection of kidney, cardiovascular, and metabolic health. Dr. Sajid serves as head of department at Pakistan Institute of Medical Sciences and brings extensive experience in managing CKD within the broader context of complex multi-system disorders with increasing recognition of CKM syndrome. Dr. Sajid has been a leading voice in emphasizing the importance of integrated care across specialties. He has contributed at national as well as international efforts aimed at advancing our understanding of this interconnected pathology and translating it into practical, evidence-based strategies for clinical practice. Today's lecture will provide us valuable insights into early detection, risk stratification, and emerging therapies, including the use of SGLT2 inhibitors and GLP-1 agonists that address not just one organ, but the entire body system. As many of you are aware of the increasingly encountering patients with overlapping conditions, which include hypertension, diabetes, and heart failure, the concept of CKM has become critically important in clinical practice. Therefore, Dr. Sajid has been at the forefront of educating healthcare professionals on this evolving paradigm, highlighting the importance of early detection, multidisciplinary management, and the use of novel therapeutics that benefit all three systems. So therefore, ladies and gentlemen, kindly join me in welcoming Dr. Sajid Rafiq Abbasi on stage for the first session of today. I would like to invite a panel of experts to please join us on stage. Professor Dr. Sami J. Khan, a huge round of applause. Professor Dr. Brigadier Retired Abdul Halim. And Professor Dr. Muneeb.
Thank you, Zunaira, for such a kind introduction. Thank you very much. So after when this lecture was signed, I came to know that if you are preparing for if you are organizing a conference, you should not take a lecture, because that's really a very tough task, because you cannot do two tasks at the same time. But I would like to, I will try my best to do both the tasks at the same time. So bridging my talk, basically topic of my lecture would be the bridging heart and kidneys, and even there some is missing, that is bridging heart, kidneys, and I think the metabolism as well. A nephrologist's role in CKM syndrome, that how basically the nephrologist should act in this complicated syndrome. That would be the topic of my talk. So that's how these three symptoms are interlinked. That is your kidney disease, basically your kidneys, your metabolism, your heart, and how they impact. That would be the topic. This is the overview. Then I'll come, and once the next. So this topic, how this emerged. Actually, this is a new concept which was taken by the Cardiovascular Kidney Metabolic Health Presidential Advisory from the American Heart Association, and this is a new concept which came in 2023 by AHA. And even when I came across this concept, and after coming to this concept, my clinical practice was changed. And in most of the patients, when I think that this is a CKM, the treatment of the patients, or even the patient's attendants, my concept to take care of them was changed. So how this has changed, so let's look at this one. So the term, so they describe that how to describe the cardiovascular kidney metabolic syndrome. So we know that there is a link between the heart and the kidney is the older one, that we know that once your kidneys are compromised, or the heart can be compromised, the heart is compromised, there can be effect on the kidneys, like we call it a renocardiac syndrome and cardiorenal syndrome. But the new concept is, which was taken in 2023 by AHA. So that is that once there's for example, the point that there is an interconnection between the cardiovascular chronic kidney disease due to the metabolic disorder, that is a diabetes and obesity. So how do they affect it? This presidential advisory introduces a consensus definition of a CKM. So the definition is that CKM syndrome is a systemic disorder characterized by pathophysiological interaction among metabolic risk factors. So you have a metabolic risk factor in the background, and which can cause a CKD, cardiovascular system leading to multi-organ dysfunction and which will result in a high rate of adverse cardiovascular outcomes. And CKM syndrome includes both individual risk for CVD and due to presence of a metabolic risk factors, CKD or both. So means you have basically a metabolic risk factor which can cause CKD either or a CVD. And if you take it for the layman, you can say CKD syndrome is a health disorder due to connection among heart disease, kidney disease, diabetes, and obesity leading to poor health outcomes. So if we look at the growing CKM burden, so CKM burden is definitely on rise along with the diabetes 2 to 3 times. So whereas the group is obese, hypertensive, and elderly individuals. So this is a prevalence data from, not from our population, but US population. So look at all the age groups, they are suffering from some kind of a CKM stage. And this is the all-cause mortality. So if you look at the all-cause mortality, generally if you are suffering from the stage of CKM, I would talk about the CKM stages, your all-cause mortality is going up. So this is one data, prevalence of obesity. So it was published in International Journal of Diabetes. So if you look at this, Pakistan is among where this obesity is quite high among the Southeast Asia. And according to the one data which was published in Daily Times, 50% of population in Pakistan is found to be obese. And the reason we know, sometimes I'm really surprised to see that whenever we, for example, go in our cafeterias, in hotels, we don't find any option what to eat. So for example, if I'm looking for some kind of a healthy diet, I can't get any healthy diet. So this is a one study basically published in CKD patients. So looking for a metabolic syndrome. So 25% of the patients, they had a metabolic syndrome. So classification and stages of CKM. So these are basically how the CKM, so stage 1 or stage 0, no CKM and no risk factors. So individuals with a normal BMI, normal waist circumference, and normal glycemia, everything is normal. We call it as stage 0, no CKM and no risk factors are there. So stage 1, excess or dysfunctional adipose tissue or adiposity. So in an overweight or obese, once you are overweight category or obesity and abdominal obesity and dysfunctional adipose tissue, and BMI is generally more than 25. And this is stage 2 is actually here, individual with the metabolic risk factors. And stage 3 is a subclinical, probably, so it's it's better looking over here. Stage 1 is a excess or dysfunctional adipose tissue, so you are obese and abdominal obesity is there, and maybe the pre-diabetes is there. So stage 2, you have a metabolic risk factor and CKD is there. So this is a stage where you're suffering from CKD already. Stage 3, subclinical cardiovascular disease. For example, you do the echo, you find there's a hypertrophy is there, or on a calcium scoring on a CT you can find, and subclinical heart failure may be there. And stage 4, you're already suffering from a clinical CVD, heart failure or atrial fibrillation is going on. But so I would talk about, these are the risk factors for CKM syndrome. So chronic inflammatory conditions like psoriasis, lupus, and high demographic groups, South Asian. So we are in the high, look at the high and low socioeconomic status. So high burden, adverse socio-demographic. So depression is there. So if you look at top risk factors, so we are in the high risk groups, so we are probably there. Type 2 diabetes and CKD. So if you have a CKD, there are more risks to have a cardiovascular disease. So this is a mechanism, so I won't talk about the lot of factors, but we know that once this is the culprit, excess dysfunctional adipose tissue. So adipose tissue is a culprit. So if you have an adipose tissue that is a dysfunctional adipose tissue, that is a toxin actually in your body, and that triggers all these inflammatory cytokines, and then you can have a problem. The first step is a metabolic syndrome. So I think everybody knows that how to diagnose a metabolic syndrome, the criteria and waist circumference and ATG levels and everything. Management goals. So let's talk about this. That's the break the cycle of RAS activation and medication and lifestyle modification. I'll talk about them in detail. Screening for CKM. So how to screen? So high-risk population screen for overweight and obesity using sex and age-specific CDC growth chart. So important is, what is the job of a nephrologist? That's important. In a high-risk population, so you go for a KDIGO guidelines and look at this one. Assessment for a UACR along with the serum creatinine and cystatin, C for accurate KDIGO screening. Those ones who are at the risk. So this is important, and more frequently for those with a higher KDIGO risk. So I would talk about the risk stratification later on. So this is the treatment chart that once you have labeled anyone as a CKM, so look for we label the CKM as a staging and treat. So this is a CKM stage 1. This is a stage 2 and stage 3, this is how the treatment is planned. So interestingly, what I see in my clinics, I see that the patient come to me with a stage 2, and generally most of the patients fall over here. They are moderate to high risk, having a chronic kidney disease with UACR of more than 30 milligram per gram, and here they get the treatment plan over here. And they attend, for example, the patients who are having either their siblings or even their daughters, sons, and they are actually lying over here. Whenever they are having the familial obesity, they are having the stage 1 obesity, they are having the CKM stage 1. So I always talk to them that if you want to avoid this stage and don't want to go to the CKD, they need to be treated over here. This is the time they need to be treated. So how to treat the CKD stage 1? The same chart actually here. So stage 1, the weight loss is the key. Lifestyle modification is indicated. But if your genetics is involved, it's very difficult to lose weight and multidisciplinary, but that is the key that need to be treated. At least 5% weight loss should be targeted with great benefit with greater weight loss. Pharmacotherapies with bariatric surgery. So bariatric surgery should be basically, we should consult them, and if the BMI is more than 30 and 40 kilogram per body meter square respectively, who are unable to achieve weight loss goal. And the drugs, I would talk about the drugs, and metformin can be considered if the diabetes is there. So this was from the JAMA review, that what are the weight reducing drugs. We know the GLP-1 agonist, I would talk about them in this talk, but rest of the one, phentermine with the topiramate and the naltrexone, bupropion, and the other drugs which are available. So this is stage 4, is not my talk because that's more like with the cardiologist. So stage 2, again, I have emphasized it a bit because we know that we are treating more for these patients. So moderate to high risk chronic kidney disease with albuminuria, UACR more than 30 milligram. So either DKD, I would talk about a little bit more here. Yeah, again, it's okay. So what is the nephrologist role? That is the talk. What is the point in detecting early stage CKD? Anyone here? So why do we get a CKD to diagnose it early on? Okay, when I started my practice and I was postgraduate resident, I always used to say, okay, pick the CKD early on. And I used to think, what is the point in detecting CKD early on? When we used to, when we need to, we will treat it with a low phos and sodium, and what is the point to detect it early on? So I was never, but when I became some wiser nephrologist, I came to know why to pick a CKD early on. This repeated question has been a barrier to improve CKD detection. For many years, the best answer has been CVD risk reduction. Because if you pick it early on, you need to treat it, and the purpose is CVD reduction. That is because most of the patients with CKD, they die of a cardiovascular mortality. So CKMs in two parameters in CKD. Whenever GFR rate and albuminuria starts, and UACR was associated with increased rate of all 10 adverse outcomes. So look at this one. So this is the way this is how we screen them. So here we start screening them. And whenever we screen them and they go in these red lines, this is the point where you should treat them. And this screening should not be done by us, not by nephrologists. That should be in the primary care physicians. So GPs or the medical specialists, they should start screening with a UACR. That is important. So obese patients, diabetic patients, UACR should be the standard. But once they go in this is the screening line, and then treatment line, and that is the red one is the referral line. And then this is the red one, the proper red one, that is where there is we call it a kidney failure. Okay, so association of CKD staging, eGFR, cystatin C, ACR categories, and risk of 10 common complications by age and multivariable adjusted analysis. So we see that whenever there is a more than 300 milligram of ACR, there is all cardiovascular mortality, and kidney failure replacement, but main is a cardiovascular mortality, and 10 risk is going up. So whenever the UACR is going up, there is a more mortality. So these are the risk prediction and risk-based prevention guidelines. So they started with the ACEB, AHA, and finally we are at the KDIGO guidelines. So this is important in CKM. So we know that for a long period of time for the cardiovascular mortality, we are using AACVD 10-year calculation, that how the patient can have risk factors. And we always used to use the calculator AACVD. But what was the problem with that calculator? That calculator never had a BMI, that never had a eGFR, so that was the problem with the calculator. In this calculator, there is a Prevent is on calculator, which includes the BMI, eGFR, and then we can use a UACR as well. So including USR, ACR, and HbA1c, we can well calculate that what is in a risk for these new calculators, that these factors can be included, and we can well calculate the risk of CVD events. This is a Prevent equation where UACR can be, and even the social demographics can be added to this one. So CKD stage 2, for example, the diabetes, I would rather simplify it in here. This is almost the KDIGO 8824 recommendations that, again, probably you know all this slide very well, that where the SGLT2 inhibitors, metformin, ROS inhibition, and role of a non-steroidal MRA, that is important. So anti-diabetic drugs, so that's important, that where this is the, look at the anti-diabetic drugs, if you consider the mass, the major adverse cardiovascular events. So if you look at these DPP4 inhibitors, they are almost, there's no factor at all. But if you look at the GLP-1 receptor agonist, they decrease the major adverse cardiovascular events. And if you look at the SGLT2 inhibitors, again, they reduce it. So a very positive impact on the major cardiovascular events. So again, the major adverse cardiovascular events with all the GLP-1 agonists, and that is the reason they have been shown to be very important in this one. And this is our favorite trial. I think that has changed the practices of nephrology, and most of the nephrologists feel very comfortable using a flow after a flow trial published in New England Journal of Medicine, a 24% low risk of composite primary outcome in those patients who used semaglutide, and we are after this one, the practices were changed, and there's a decrease in cardiovascular mortality with CKD. And these are the main trials which were done with the SGLT2 inhibitors in patients. All the main trials with SGLT2 inhibitors, few of them were purely with CKD, and all the risk reductions, cardiovascular benefits, so all the trials with SGLT2 inhibitors. So this is an important trial with the dapagliflozin showing, this is actually not the main trial, but just data which was extracted from the trial, subgroup analysis that showed those patients who were on dapagliflozin, the kidney failure was delayed from 6.3 years, the decline in kidney function 6.8 years, and hospitalization 6.2 years, and all-cause mortality 3 years. So few about the finerenone. So mineralocorticoid, we know this is a mineralocorticoid receptor antagonist, and overstimulation. I think finerenone is it's a non-steroidal and selective antagonist, and it has a high potency. But when to use, that's important. Sorry. That's important. These were the two trials I think you have gone through a number of times through this trial. But when to use it, that's important. Here, this is the clear in stage 2, and DKD with residual albuminuria, once the patient has been optimized on renin-angiotensin system blockade, and still and your urine ACR is more than 30 milligram per gram, potassium you should monitor it, and then those patients should be added to the finerenone once you have blockaded it. So this is how it's addressed in KDIGO and ADA guidelines. And this is the 4-pillar approach in DKD we should always kept in mind. And GLP-1 agonist, non-steroidal, MRA, ROS blockade, and SGLT2 inhibitors. And finally, this is how our hero looks like finally. Thank you very much.
Thank you, Dr. Sajid, for such an insightful, informative, and clinically enriched presentation. So the house is open for question-answer session. Okay, we'll resume our session after a short tea break. So join us for tea.
Sorry, अच्छा ये सेशन क्वेश्चन आंसर कर लें और एक और कर लें ये last session was sponsored by Hilton, although this question answer session कर लें. Yes, sir.
Thank you. Assalamu alaikum. Thank you very much, Sajid. मुझे नहीं पता हलीम सर बैठे हैं. It's a terminology bombardment actually. What is new in it? I just want to know. American Heart Association ने कुछ publications कर दी. Metabolic syndrome वहीं पे था सर. Chronic kidney disease को बीच में घुसा दिए. जैसे आज तक cardio-renal syndrome की समझ नहीं आई कि उसका क्या फ़ायदा है. So मुझे इस concept की सर frankly I couldn't understand that what is new in it. We have patients who are obese. They have risk factor for chronic kidney disease. They have risk factor for cardiovascular disease. So introducing a new term, how it is going to change anything? Is it kidney disease centric approach? What they want to actually mention? Because overall, if you just come to the management, it won't change anything, you know. So मुझे आपका नहीं, आई मीन जिन्होंने इंट्रोड्यूस कर दिया एक और टर्म हम स्टूडेंट्स के लिए, तब के लिए, आई डोंट नो व्हाट वी विल गेट आउट ऑफ इट एट द एंड ऑफ द डे.
आई टोटली एग्री विद यू. साजिद बाद में जवाब देगा. पहले अगर आपको याद हो, हम पहले से सुनते हैं कि ये चीज़ दिल गुर्दे का काम है. सुना ना आपने ये मुहावरा? दिल लिवर और दिल के साथ लंग्स नहीं आए, दिल के साथ गुर्दे आए. और जो आप सब लोग प्रैक्टिस करते हैं, जैसा मेरी आदत है, आपकी भी आदत है कि राइट साइड पे आप डिजीज़ लिखते हैं जब भी पेशेंट आता है. प्रॉब्ली सबसे ज़्यादा कम्बिनेशन डायबिटीज़, CKD, हाइपरटेंशन, ये तकरीबन मेजॉरिटी पेशेंट में होती है. बल्कि मुझे कल खुद अपने आप पे हंसी आ रही थी, तो वो पेशेंट डायबिटिक नहीं था. तो मैंने ऊपर देखो, मैंने 3 दफ़ा उससे पूछा डायबिटिक तो नहीं है. तो इट्स सो कॉमन. जब आप डायलिसिस में देखते हैं तो प्रॉब्ली 2/3 ऑफ पेशेंट्स आर डायबिटिक, हाइपरटेंशन, CKD. और जहाँ तक तल्लक वेट का है, और ये टोटल एक एसोसिएशन कॉमन है इन सब के साथ. वेट रिडक्शन की बात तो ठीक है, सबको एक्सपीरियंस है अच्छा भला. वो पूछते होते हैं कि जी वज़न कम करने के लिए क्या खाना पड़ेगा. मैं कहता हूँ जी खाना कम करना पड़ेगा, क्या खाना नहीं पड़ेगा. दूसरा मेरा एक कमेंट है, व्हेन आई वाज वर्किंग इन UK, तो आप जिन लोगों ने काम किया आपको वहाँ इल्म होगा कि यूरोपियन में डायबिटिक पेशेंट्स जो हैं वो इतना कॉमनली CKD में नहीं जाते या डायबिटिक नेफ्रोपैथी में नहीं जाते. तो ये उनकी वहाँ ऑब्जर्वेशन थी व्हेन आई वाज वर्किंग इन हैमरस्मिथ कि साउथ एशियन जेनेटिकली दे आर मोर प्रोन टू डायबिटिक की कम्प्लिकेशन जो नेफ्रोपैथी साइड की हैं, उनमें इतनी कॉमन नहीं है ये, और हमारे लोगों में ये ज़्यादा कॉमन है. तो बाकी जहाँ तरह एक कम्बिनेशन की, ये कम्बिनेशन तो हम देखते हैं, प्रॉब्ली इसको एक ऑर्गेनाइज तरीके से डिस्क्राइब किया गया है, दैट्स ऑल. ये कोई नई कम्बिनेशन नहीं है, ये हर एक को पता है. तो साजिद ने जो जिसका कसूर नहीं है, जिन्होंने डिस्क्राइब किया, साजिद ने उसको अच्छे तरीके से हमारे सामने प्रेजेंट किया. दैट्स व्हाई आई कैन से.
I think I would add on to it, it's an old wine in a new bottle.
अच्छा, उसमें मैं ये कहूँगा कि ये 4-5 डिजीज़ जो हैं CKD में जो डाली हैं सिंड्रोम में, तो उनके ट्रीटमेंट जो आजकल नई जो ड्रग्स आई हैं, 1-2 मैजिक ड्रग जैसे आप लोग कहते हैं ना, तो सबका इफेक्ट इन सब डिजीज़ पर होता है. तो इस वजह से उसमें सिंड्रोम में मतलब एक डाल के उसे मैनेजमेंट में आसानी हो गई, और साजिद साहब को समझाना आसान हो गया मेरे ख्याल में ना. तीसरी बात ये कि ये जितने भी डिजीज़ सब सोशल डिजीज़ बिकॉज रिलेटेड टू योर लाइफ स्टाइल एंड ऑल्सो बेटर इम्प्रूवमेंट ऑफ योर लिविंग स्टैंडर्ड्स. तो इसमें सबसे पहले मेरे ख्याल प्रिवेंशन पार्ट जो होता है इट्स वेरी इंपॉर्टेंट. इन प्रिवेंशन पार्ट यू शुड गो इन पब्लिक अवेयरनेस थ्रू सोशल मीडिया एंड अर्ली स्क्रीनिंग एंड डिटेक्शन. So we will not approach on this stage of syndrome and also it's very cost effective and reduce a lot of burden on our economy and hospital budget, etc.
मेरी ऑब्जर्वेशन है, कराची में मैंने ये कहा था कि जो फैमिली फिजिशियन हमारे पास पेशेंट भेजते हैं, वो भेजते हैं खुद आप हमारे पास आ जाते हैं. ये माइक्रो एल्ब्यूमिन यूरिया का इतना वो रिवाज पड़ चुका है कि इवन व्हेन द थिंग्स आर सो ऑब्वियस, ये माइक्रो एल्ब्यूमिन यूरिया का टेस्ट हमने ज़रूर कराना. ये पता नहीं आपकी क्या ऑब्जर्वेशन है, पता नहीं क्या ऑब्जर्वेशन है. तो मेरी रिक्वेस्ट ये है कि प्लीज़ यहाँ तक हो सके जब भी आपका इनकाउंटर होता है, किसी न किसी तरीके से ये इस चीज़ को आम करें कि जब प्रोटीन यूरिया पहले मौजूद है तो हम माइक्रो के पीछे क्यों कितना पढ़ना चाहते हैं. जस्ट टू लेट पीपल नो कि हमें पता है माइक्रो क्या होता है. मतलब आपको पता है कि हाउ एक्सपेंसिव द टेस्ट इज. मतलब रूटीन जो है या यूरिन कंप्लीट एग्जामिनेशन विल कॉस्ट यू ओनली 200 या द मोस्ट 300, और दिस कॉस्ट मोर देन 800. इकोनॉमिक्स पहले ही पाकिस्तान की आपको पता क्या है, और कुछ नहीं कर सकते, कम से कम गरीबों के लिए पैसे ही कुछ बचाएं. इतना लेबॉर्ट्रीज को खुश करने की कोशिश ना करें, उनको खुश करने के और बहुत तरीके हैं. ये गरीबों पर बोझ ना डालें. ये मैंने कहना प्लीज इसको, ये बड़ी सर्विस होगी गरीबों की.
तो सर का एहतराम करते हुए अभी डेयर टू डिफर सर, अभी जो सारी अप्रोच है सर, वो हमें माइक्रो से पहले भी हमें मार्कर्स मिल जाए डायबिटिक नेफ्रोपैथी की, तो बड़ी अच्छी बात हम करें. दिस इज़ द ओनली थिंग कि हमें उन्हें इनकरेज करना चाहिए. इफ़ यू थिंक सो, डिपस्टिक से एक दफ़ा कराएं, पॉजिटिव आता है, दूसरा कराएं, +1 आता है, देन गो फॉर microalbuminuria. And if it is there, now we have got so many pivotal things that we can intervene at the right time. RAS से लेके GLP-1 agonist से लेके और fineron से लेके सर.
सुना कि जब 30 से 300 आपकी रेंज है माइक्रो एल्बुमिन, तो जब फ्रैंक प्रोटीन यूरिया है तो फिर क्या ज़रूरत है गोइंग बैक टू, लेट्स से उसका प्रोटीन 1 ग्राम है या 2.5 ग्राम है, तो बस फिर आई डोंट थिंक
वी शुड ट्राई टू पिक इट अर्ली. सर की बात बड़ी वाज़ेह है.
कोई आदमी आपसे डिसएग्री नहीं कर रहा.
एक ही बात दोनों का.
सर तो इसलिए छोटी बात कर रहे हैं, बड़ी बात कर रहे हैं, बात है बड़ी ज़रूरी. तो हम
मैं कुछ Sir, should I answer? Can I say something? Sir, my point on this is probably that we are coming to that era where we feel that probably diabetes, hypertension, and ischemic heart disease, that combination was there, is there, and will there. So there is no doubt about that. But now I think science, probably the medical science feels that obesity needs to be treated and needs to be treated aggressively. And that's why they have said that CKM term has been defined, and if you look at even the definition, that obesity is causing all the problems. And unless we treat obesity and bring down the weight first, we cannot treat anyone. So for example, even I do this practice. For example, if the patient comes to me, I call them directly. For example, if the BMI is 30, I said, you don't do anything, go for a bariatric surgery, or go for a GLP-1 agonist. If you don't lose your weight, you can't do anything. And that's straight away, and now the medical science is very clear. You go for a bariatric surgery today, you won't be diabetic after 5 years, and you won't spend your money on a ischemic heart disease, you won't spend your money on a osteoarthritis, on a knee replacement, because science is getting clear. So that's why they are trying to say this is a CKM, and that's a CKM, are either 1 or 2. So that's more scientific approach, and that's why CKM. So although the diabetes, hypertension, everything was there 5 years back, but defining CKM, that CKM needs to be treated through reducing obesity rather than treating diabetes with something like glucophage and SGLT2 inhibitors. It should be treated with semaglutide and maybe a GLP-GIP combination and tirzepatide, and bringing down the weight. And once the weight is reduced, all the pathology would be changed. I think this is my view on this one. So I take this pathology like this.
Any other questions, comments?
So weight कम हो जाएगा, osteoarthritis of the knees कम हो जाएगा, NSAIDs कम हो जाएंगी, disease.
No, I told you what I do is my patient comes to me and I tell their attendants, go for a bariatric surgery today, and tomorrow you won't be like this patient, and that's the way to take the patients. Because otherwise, genetic obesity cannot be treated with the diet or with the exercise. That has been seen in multiple studies. Only the bariatrics can do the job, or maybe tomorrow something advanced than Wegovy and maybe tirzepatide can do the job, but it cannot be done with the diet alone. Thank you very much. And this session was sponsored by Hilton. I forgot it, but this was purely education session.
So now we can have a short tea break. Yes. So we'll resume our session after this break.